We'll get started. Welcome everyone to another High Rounds. We're winding down for the year. This is a really exciting talk, though. I'm really excited that Laura Bamford is going to be able to talk to us. But we also realize it's her first time presenting to this group, so she gets a real, or second time giving a talk, but the first time as faculty with us. So just by way of introductions, Dr. Laura Bamford is a clinical associate professor of medicine, and she is the new director of the Owen Clinic in the Division of Infectious Diseases and Global Public Health. She completed her internal medicine residency at Columbia University in New York and her infectious diseases fellowship at the Hospital of the University of Pennsylvania. Prior to joining UCSD over the summer, she was faculty in the Infectious Diseases Division at Penn and the medical director of Clinica Bienestar within Philadelphia's Syringe Service Program, Prevention Point, Philadelphia. She has so much to share with us in relationship to the opioid epidemic, and I think what's happening now in the era of COVID is going to be really interesting. So I will pass it over to Laura. I will just say, please share comments in the chat. If you want to just direct them to me privately, you're more than welcome to do that. I will interrupt Laura just for clarifications and then try to have a dialogue by the end. And Laura, I'll let you know when it's 7:45. All right, take it away.
Thank you. Thank you so much, Jill, for that kind introduction. All right. So let's see. I have no disclosures. And before we get started with the talk, I wanted to remind everyone about the principles of harm reduction. I think now more than ever, during the COVID-19 pandemic, when our patients are struggling more than ever with stress and isolation and mental health and substance use disorders, it's really important to remember these principles. And we're going to talk about a number of the harm reduction tools that we have for patients living with substance use disorders. But harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. And it's a movement for social justice built on beliefs and respects for the rights of people who use drugs. And then also, again, because so many of our patients are struggling, during the pandemic with mental health and substance use disorders, it's extra important to be screening our patients for these disorders. In order to do that, we really need to use language that is non-stigmatizing, and so that our patients feel comfortable disclosing when they've started to use, when they've increased their use, when they've relapsed. And this is a list of terms from the American Society of Addiction Medicine, and just to remind us of some terms that can be very stigmatizing that we should avoid. So calling patients addicts or abusers or users, junkies, druggies is highly stigmatizing. And instead we should use terms like persons with substance use disorders or opioid use disorders. Instead of using alcoholic or drunk, refer to our individuals who drink alcohol to access as persons with alcohol use disorder. Instead of saying oxy addict or meth head, say persons with opioid use disorder. Instead of saying someone's an ex-addict or a former alcoholic, that they're an individual in recovery. And then when we refer to laboratory tests related to substance use or urine toxicology results, and instead of referring to those results are clean or dirty, refer to them as we do with any other lab tests, as either negative or positive or as expected and not as expected. And then finally, referring to the disorders themselves, not as addictions or addictive disorders, but addiction and substance use disorders. All right, so before we talk about 2020, I wanted to talk about where we were in 2019 before the advent of the COVID pandemic. And at the end of 2019, almost 72,000 Americans were reported to have died from drug-related overdoses. And this was a 5% increase compared to 2018. And there was some hope in 2018 because at that point, for the first time in 30 years, we had seen a decline in drug-related overdose deaths in the United States. And that decline was largely attributed to declines in prescription opioid overdoses with changing prescribing habits of providers. But then by 2019, we saw a 5% increase compared to 2018. And this is largely driven by the fentanyl epidemic. And you can see from this graph that, even when heroin deaths and deaths involving prescription opioids declined from 2017 to 2019, we continued to see an increase in fentanyl deaths and also deaths related to methamphetamine and cocaine. And all three of those are really what are driving the substance use disorder epidemic and these deaths, these exponential deaths in the United States. So, as I mentioned, most of these deaths are related to fentanyl, and fentanyl, is an opioid, so it's a synthetic opioid. It is 50 to 100 times more potent than heroin, and it makes its way into the drug supply in the United States by several mechanisms. So it's mostly sent by mail from China and India. So either the fentanyl itself or its precursors are shipped to Canada and the United States and Mexico. And then mostly in Mexico, it's further processed in either mixed with heroin or processed into pills and then smuggled into the United States. So again, it's mixed with heroin. It's been found to be mixed with cocaine and methamphetamine, found pressed into pills and sold on the street as oxycodone and Xanax. And so, most of the times when it's in the cocaine or methamphetamine or pressed into the pills, the person who's using it doesn't even know that it's there. And, because, the fentanyl is being processed in clandestine labs, when it's mixed into heroin or into cocaine or methamphetamine or pressed into pills, isn't necessarily always done so with the same allotments. And so, when people are using these substances, it's like playing Russian roulette. One pill that they take can have a very different level of fentanyl compared to the next. And patients or individuals aren't able to detect it by presence, sight, taste, or smell. So very important that we're all reminding our patients to take precautions, that it could be in any of the substances that they're using. And so what's happening in the United States as a whole, broken down by state, and these are the reported drug overdoses from between March 2019 and March 2020. So just prior to the advent of the COVID-19 epidemic. And I just wanted to show all of you this one, that while many states in the US, those in blue and light orange, did see reductions in overdose deaths in 2019 and into 2020, California saw a 24% increase in overdose deaths, and really driven by fentanyl, but also methamphetamine. And in the past, it has been difficult to mix fentanyl into the heroin supply on the West Coast, because the heroin supply on the West Coast has largely been black tar heroin. And if you mixed a white powder into that, it clearly would change its consistency, its color. But as more powdered heroin and powdered methamphetamine make its way to California, it's been easier to disguise the fentanyl there, and therefore we're seeing this huge surge in overdoses. I should note that some of this increase in overdoses may be a reporting artifact, and that maybe more medical examiners are actually checking for fentanyl in their urine toxicology reports. So this may artificially increase the numbers if we weren't detecting it previously. Okay, and this is a graph from the CDC that looked at 25 jurisdictions across the United States. So 24 states and the District of Columbia, and it looked at drug overdose deaths during January through June of 2019. And this is just a breakdown of the substances that they were finding. So you can see that in the Northeast and the Midwest, these drug-related deaths are really driven by opioids. And as you move west, you're seeing more stimulants driving these overdose deaths until we get to the West. And still in the West, opioids, do make up the largest percentage of deaths, but compared to the East, far more stimulants and combining of stimulants and opioids than is seen in the Midwest and the Northeast. And then this is from the same MMWR report of those 25 jurisdictions across the United States. And this was data that was abstracted from death certificates, medical examiners, coroner reports, and death scene investigations. And what this highlights is about 2/3 of individuals who died of an overdose in these 25 jurisdictions had at least one potential opportunity or one missed opportunity, where someone could have intervened to perhaps prevent that overdose. You can see that about 10% of individuals had a recent release from the Department of Corrections. Even prior to COVID-19, there often wasn't, often weren't warm handoffs from the Department of Corrections when people were leaving to either inpatient substance use disorder treatment programs or outpatient programs. And when people are incarcerated, people with substance use disorders are incarcerated, particularly those with opioid use disorders, and don't have access to the opioids. Their opioid tolerance upon release is, can be very low, and that's a huge risk time for fatal overdose. Also, about 10% of folks had a previous overdose, and again, an excellent opportunity to refer people to substance use disorder treatment. There's about 25% of individuals with comorbid mental health diagnoses, and so really important to not only treat the substance use disorder, but treat the underlying mental health disorder. About 20% were ever treated for substance use disorders. So these are people that have access to treatment, but for some reason weren't successful, and whether the treatment was paired with medication-assisted treatment or they were purely detox programs alone is unclear. And then finally, about 40% of these fatal overdoses had a bystander present, which really highlights the need for more Narcan distribution and Narcan education, so that friends and family members or people on the street have Narcan available to reverse fatal overdoses. Okay, so what is the impact of COVID-19 on individuals with substance use disorders? So, it's hypothesized that access to substance use disorder treatment programs and peer support groups has markedly decreased. And then syringe service program operations are severely limited, limiting access to clean syringes and injection equipment, which may cause people to share more and result in more transmission of HIV and hepatitis C, increased risk for serious bacterial and fungal infections. The focus of emergency departments has shifted to COVID-19, and people with substance use disorders, do use the emergency department often as their primary care. A number of emergency departments have also been active in starting people on medication-assisted treatment, and a lot of those efforts, those priorities have needed to shift to focus on COVID-19. The pandemic creates increased isolation and stress, which may increase substance use and trigger its relapse. Individuals are very isolated today, and when you're isolated in your own home or apartment, that increases your risk of fatal overdose if no one is around to reverse an overdose. There's decreased bystander overdose rescue. There are just fewer people out and about, fewer people in restaurants, and a lot of people do use in bathrooms in restaurants, and so there wouldn't be bystanders available to call 911 or administer Narcan. with decrease in inconsistent income during COVID-19 that can cause inconsistent substance use. And so when folks have inconsistent income, they may be using opioids in particular less consistently, so that may decrease tolerance, and therefore when they do use, increase their risk of fatal overdose. When people need to access illicit drugs, that makes staying in place very challenging. So people may be unable to social distance or protect themselves from COVID in the way others can. Also, it's difficult to isolate when you're homeless, and there's certainly higher levels of homelessness amongst people with substance use disorders. And also amongst people who are incarcerated, there are higher rates of people with substance use disorders. So difficult to isolate in the Department of Corrections. The illicit drug supply may be disrupted and be more unpredictable during COVID, which again can make, because that makes the supply more intermittent, can also decrease people's tolerance. And also people, again, just like I mentioned, that many substances like heroin and cocaine and methamphetamine can be adulterated with fentanyl. There's concern that, with the drug supply being limited, that it's really unknown what is being sold on the street, and what people think they're buying may not at all be what they're buying. There's been humane early release of incarcerated individuals because of risk for COVID-19, but that also poses risks. As I mentioned, without a warm handoff, these folks are at very high risk of fatal overdose, and often, with decreased access to substance use disorder treatment programs during COVID, it leaves people without a safety net upon release. And then finally, as everyone's efforts have been shifted to COVID-19, and there's likely decreased access to HIV and hepatitis C testing. So this was a brief report from the American Medical Association. Was really a collection of lay news reports across the country, but reporting increased opioid and other drug-related overdoses. And so more than 40 states have reported increase in opioid-related mortality since the start of the epidemic. And drug-related overdose deaths are estimated to have risen an average of 13% so far in 2020 compared to 2019. And this is a site called the Overdose Detection Mapping Application Program, and I've put the website at the bottom right here. But this is an organization that collects reports from 1,201 agencies across the country. So first responders, so police departments and fire departments related to overdose deaths. And the first responders could actually send text messages to ODMAP when they encounter an overdose, and with like a little algorithm to give them characteristics about the overdose. Was it a fatal overdose, substances that were involved? And based on the information they have since January of 2019, they project that there's, for every 10 suspected overdoses reported in May 2019, that there are 14 overdoses that are reported as of May 2020. And this represents an increase up to 42% per month during the pandemic compared to the same months in 2019. And then this is also a report, again, just from reports from some local health departments, coroners, and medical examiners that show by state, some of the states have seen the highest increase in drug-related deaths in the first half of 2020 compared to 2019. And you can see here in California, it's estimated that we've seen a 23% increase in overdose deaths so far. And this is what's happening here in San Diego. So data that we have, and this is from the California Health Alert Network, and data that we have back to 2000, and this is fentanyl-related deaths specifically. There were very few deaths, over the last 20 years until the last 2 years. And in 2019, we saw 152 confirmed deaths that contained fentanyl. And as of August of 2020, we've already surpassed that, and with 233 either confirmed or suspected overdose deaths. And currently it's projected that about 3 San Diegans are dying from overdoses a day. And this is a report from an urban emergency department in Virginia, at Virginia Commonwealth University, looking at non-fatal overdoses that had presented to their emergency department during the COVID-19 pandemic. And the total number of non-fatal opioid overdoses visits to their emergency department increased from 102 between March and June 2019 to 227 between March and June 2020. And this is at a time, and I think, across the country, we've seen this phenomenon that the total number of acute myocardial infarction diagnoses decreased in the same time period at this emergency department from 41 to 31. And the number of all emergency department visits decreased from 36,000 to 26,000 during the same time period. All right, and this is a study in molecular psychiatry that looked at health medical records across the country. So 73 million individuals that contributed to this electronic medical record. And it's a retrospective case control study, again, with 63 million unique patients, and of whom 12,000 had a diagnosis of COVID-19. And in these analyses, they adjusted for age, gender, race, and insurance type, and they looked at the risk between recent substance use disorder diagnosis, which they used as a surrogate for recent use of substances, and risk of COVID-19 acquisition. And by COVID-19 acquisition, this is really symptomatic COVID. This study looked at these patients during March and June of this year. So really before we were doing a lot of testing for asymptomatic COVID. And what they found is that individuals with recent or ongoing substance use disorder had 8.7 times the risk of acquiring COVID compared to individuals without a substance use disorder. And in particular, those with opioid use disorder had 10 times the risk of acquiring COVID compared to individuals without substance use disorders. And one thing that they hypothesized is that individuals with recent substance use disorders also had significantly increased rates of chronic disease, chronic liver disease, kidney disease, lung disease, cardiovascular disease. And so this may in part explain these increased risks. But because the opioid use disorder risk was so much higher, even compared to the overall risk of substance use disorder, they also hypothesized, is there something about opioid use disorder that further increases someone's risk? And perhaps that's the respiratory depressant effect of opioids that may further increase someone's risk of COVID symptoms. And then here are outcomes in patients with COVID-19 and substance use disorder broken down by race. And so first, when they looked at all folks who were diagnosed with COVID in this cohort, they found what we've seen nationally, that African Americans were a significantly higher risk of death related to COVID compared to Caucasians, which was even further magnified when you looked at African Americans versus Caucasians with substance use disorders. When they looked at individuals, and this is all substance use disorders, so chronic substance use, when they looked at individuals with more recent substance use disorders or more active substance use disorders, there was not a significant difference in deaths related to COVID between African Americans and Caucasians. And they hypothesized that perhaps because with the recent substance use disorders, likely more Caucasians have a history of opioid use disorder or recent opioid use disorder, and maybe that same reason that opioid use disorders seem to increase one's risk of COVID-19 acquisition because of respiratory depression. It may be that may be making up for some of the other disparities between African Americans and Caucasians. And then this is a map of the United States with some recent outbreaks of HIV. And this was prior to the COVID-19 epidemic, but concerning if we are doing less testing for HIV, what is happening since March. So between 2016 and 2019, several areas in the United States saw outbreaks. So in Seattle, Portland, Oregon, Northern Kentucky, and Hamilton County, Ohio, Lawrence and Lowell, Massachusetts, Caldwell County, West Virginia, and in Philadelphia. And some of the things that united all of these different epidemics were most of the individuals, all with a history of injection drug use, and most were injecting either fentanyl or methamphetamine or a combination of both, and sometimes a combination of fentanyl and cocaine. And the other thing, some other demographics that really united all of these epidemics were most of these new diagnoses had a history of recent incarceration, a history of homelessness, and a history of hepatitis C antibody, which we know is a marker for shared injection equipment. And one other thing to note is that all of these different health departments performed molecular analyses of the HIV isolates and found that they were less than 0.5% different. And so, which suggests not only that these are transmissions from the same individuals in these different communities, but also that the transmissions happened very recently. And so this is HIV incidence between 2014 and 2018. And what it shows is that pretty much for all HIV transmission categories, we've seen a decline in incidence since 2014, really with the exception of injection drug use. And in fact, we've seen an 11% increase in HIV incidence among individuals who inject drugs between 2016 and 2018. And similarly for hepatitis C, from about 2011 through 2018, we've seen a four-fold increase in new hepatitis C infections. And you can see this is really driven by the younger age group, so between 19 and 40 years old. And again, driven by the opioid epidemic. And just prior to the COVID-19 epidemic, this was a study of HIV and Hep C testing among commercially insured persons who inject drugs in the United States. And the study utilized ICD-9, ICD-10, and CPT codes from a national health insurance database to identify diagnoses that might be indicative of injection drug use. So things like opioid use disorder or substance use disorder, or recent endocarditis, osteomyelitis, skin and soft tissue infection. And they identified 844,242 individuals with clinical encounters that were suggestive of injection drug use. And of those, only 8.5% were tested for HIV, and only 7.7% were tested for hepatitis C during this period. And the things that were significantly associated with not being tested were, despite these high risks, were being male, a rural residence, and receiving services for skin and soft tissue infections and endocarditis. And so the authors, some of the limitations of the study, the authors, first of all, point out that these are individuals with commercial insurance. So perhaps there's some illicit bias on the part of providers in not offering tests to people with commercial insurance. but also concerning because these are individuals who have access to the testing and also access to follow-up in the event of a positive HIV or hepatitis C test. So this was an interesting study that was recently presented at ID Week. You know, and we don't have a lot of data right now about what is happening with HIV testing in the United States during COVID. But this was a study from 13 emergency departments in Chicago. So between January 1st, 2020 and August 17th, 2020, researchers in Chicago observed a decrease in HIV screening in these 13 emergency departments in their city, you know, likely because of, again, shifting priorities in emergency departments, you know, to COVID-19. But during the same time period, there's an increase in patients who were diagnosed with acute HIV infection in these emergency departments. And so the researchers hypothesized that many of these patients were likely presenting with symptoms that they had attributed to COVID-19, but were in fact acute retroviral syndrome. And in fact, the rate of these acute HIV infections in these emergency departments was significantly higher in the first 8 months of 2020 compared to the prior 4 years in any of these emergency departments. So these data suggest that HIV screening should really be included as part of COVID-19 testing efforts, you know, particularly in emergency departments, and be really great if we could even do it in some of the drive-through centers, though we'd have to work out the logistics of, you know, even with the point of care fourth generation tests, there's still about a 15 to 20 minute wait time on results, but would be a great way perhaps to identify more people really early in infection, but also continue with, you know, important screening efforts during COVID-19. And then this is, you know, and again, we don't have you know, much data right now on what's happening with hepatitis C screening rates during COVID, but this is a mathematical model, a Markov model, about what is the global impact of a 1-year delay in HCV screening programs if we did you know, no diagnosis of new new hepatitis C cases, and if we treated no one for hepatitis C, you know, during this, you know, during 2020. So really a worst case scenario. And these, again, are based on mathematical models that had originally been utilized by the WHO to come up with their 2030 targets for hep C elimination. So what this model shows is that, you know, if we just halt you know, screening and we halt treatment, that means that, you know, 906,000 individuals will go undiagnosed, and 746,000 individuals will go untreated. And this could result in 121,000 incident hep C cases, an additional 121,000 hep C cases, an additional 72,300 liver-related deaths, and an additional 44,800 cases of hepatocellular carcinoma, which would then ultimately result in 623,000 increase in prevalent cases of hepatitis C. All right, so I'm going to talk now about some of the harm reduction strategies that we have to combat the opioid epidemic, and in particular what you know, some of these strategies are doing during COVID, you know, to combat COVID and continue to offer their services. So first, some of the benefits of syringe service programs. So in addition to providing individuals with sterile syringes and needles and clean injection equipment, you know, they're really a hub of a whole bunch of services, and really a place for people with substance use disorders can go to access these services in a way that they really can't access them or don't feel comfortable accessing them elsewhere. And so syringe service programs, in addition to providing the injection equipment, provide hepatitis C and HIV screening. They refer individuals to substance use disorder treatment. Many of them provide on-site medication-assisted treatment. A lot refer individuals to mental health services. Some provide some basic wound care. Many provide vaccinations, particularly for hepatitis A and hepatitis B. So really important to continue to support them and make sure that they can carry on during the COVID pandemic. And many of them are, have really strategized ways to meet people where they're at, offering a lot of services outside. Many are distributing, a lot of syringe service programs deliver or exchange syringes and needle on a one-to-one basis. So you must return a single syringe to get one additional, and a lot have relaxed some of those policies so that folks can get them more in a needs-based manner, and also exchange for others, to limit the number of people having to present to serve, for these services, that they can give enough syringes that people can take for their friends. And what's happening in San Diego with syringe service programs. So in March, the county voted to finally end the ban on syringe service programs in San Diego, and is working to develop its own syringe service program, which is amazing news. And until then, you can still refer folks to Family Health Centers of San Diego. They have several mobile sites that will exchange syringes. And very recently, the Harm Reduction Coalition of San Diego County was awarded state funds to be able to start their own syringe service program. And I know they're working on some mobile efforts to get more syringes to the people who need them most. And then finally, and if patients don't have access to these syringe service programs, or feel stigmatized about presenting there, all providers, at least in 48 states, with the exception of Kansas and Delaware, can actually prescribe syringes. So on a prescription pad, anyone who has prescribing privileges can order insulin syringes with the ICD-10 diagnosis code of substance use disorder or HIV prevention, and patients can access them in any pharmacy in California. Okay, and then on to supervised consumption sites. Some of their benefits listed here: they reduce overdose deaths, they decrease HIV and hepatitis C transmission, they decrease the acquisition of bacterial and fungal infections. They're effective referral sites for substance use disorder treatment and primary medical care. They're associated with decreased public injection and safe syringe disposal, and they've not been shown to lead to increased drug use, increased crime, or increased drug trafficking in their communities. And this is a picture of this supervised consumption site in Vancouver, Canada, which has been the one that's been the most studied. And there are over 100 supervised consumption sites in 11 countries around the world. And in addition to doing all of these things, they provide a space for people to bring pre-obtained drugs and use them under sterile conditions with sterile supplies. And in these over 100 sites across the world, they've seen tens of thousands of overdoses, and never once have had a fatal overdose inside their buildings. And this is a letter to the editor in the New York Times, in the New England Journal of Medicine from August. And this is highlighting an unsanctioned safe consumption site in the United States. So in September 2014, in response to a local overdose crisis, an organization opened an unsanctioned site in an undisclosed city in the United States. And here they're highlighting their results. So over time, they've seen many, many more injection sites and more opioid overdoses. But since September of 2014, have never had a fatal overdose. And then an update on Safe House. So Safe House is the proposed supervised consumption site, or as they like to call themselves, the opioid overdose prevention site in Philadelphia. which was actually legalized in October 2019. So first in February 2019, the U.S. Attorney for the Eastern District of Pennsylvania filed a civil lawsuit asking a federal court to declare that supervised consumption sites are illegal under this statute, which unfortunately colloquially is known as the crack house statute, which makes it a felony to knowingly open, lease, rent, use, or maintain any place for the purchase of manufacturing, distributing, or using any controlled substance. But in October 2nd, 2019, a judge ruled that the ultimate goal of Safe House proposed operation is to reduce drug use, not facilitate it, and accordingly does not prohibit Safe House's proposed conduct. So essentially legalized supervised consumption sites in the United States. But after that ruling, the U.S. District Attorney of the Eastern District of Pennsylvania filed an appeal, and that appeals process is going to start again on Monday. There was a hold on it, because of the pandemic, but on Monday, Safe House is scheduled to appear in the Third Circuit Court of Appeals to begin remote oral arguments. So I think this will be extraordinarily important and interesting, because whatever happens in this case will really set the precedents for the rest of the United States, and hoping we can move to the legalization of these safe consumption sites. All right. And then I'm going to talk a little bit about medication-assisted treatment and its benefits. So it's medication-assisted treatment, which comes in 3 different forms for opioid use disorder: buprenorphine, methadone, and long-acting injectable naltrexone. Has been shown to reduce drug-related overdose deaths. It reduces HIV and hepatitis C acquisition, and also violent crimes, and it improves treatment outcomes overall. And so during the COVID-19 pandemic, both SAMHSA and the DEA have made provisions for methadone and buprenorphine distribution to treat opioid use disorder during this COVID-19 emergency. So first of all, under the CARES Act, which has allowed states to expand Medicaid, that has increased access for people with substance use disorders to MAT and naloxone. And when the Affordable Care Act was enacted several years ago, that also increased access to buprenorphine and naloxone. And so the hope is with this current expansion during the CARES Act that will further increase expansion to people who need it. Currently, only about 20% of individuals with opioid use disorder actually have access to buprenorphine treatment. So we really need to increase those efforts and get more people waivered to be able to prescribe buprenorphine. The DEA and SAMHSA also eased restrictions on the dispensing of methadone. So folks still need to present to a methadone maintenance program to initiate methadone. And the reason is that often people are only initiated at like 30 to 40 milligrams, which really isn't going to be a dose that can sustain somebody. And so, to be able to give take home, it would be really difficult to be able to kind of very quickly, taper up a methadone dose, with take home doses. And so at least for the first 2 weeks, patients are still required to present on site to the methadone maintenance programs. But after that, once they meet a steady dose, then folks can receive up to 2 weeks of take-home doses, which is really great to be able to decrease risk of COVID. And actually, other clinics that had enacted this before, when people are really stable, when people are given take-home doses, it actually decreases people's risk of acquisition of HIV and hepatitis C and bacterial and fungal infections, likely because they're actually taking the methadone every single day. It's very challenging for folks to go to a methadone maintenance program, and even folks that are supposed to present there every day often do not and end up still using or injecting in between. And then one other reason why and they want people at least initially to check in with the methadone maintenance program, as there still is a requirement for a physical exam prior to starting methadone, and also EKG monitoring, because methadone can increase the QT, can prolong the QT interval, particularly at doses over 100 milligrams. And then there's been some really great relaxation of regulations regarding the prescribing of buprenorphine as well. And buprenorphine can be initiated via telemedicine, either a video visit or telephone visit, and then continued that way. So the DEA and SAMHSA have relaxed the requirements for initial physical exam for folks starting buprenorphine, and also for monitoring urine toxicology results. So buprenorphine prescription can now be given completely via telephone and telemedicine, which is really great to increase access and prevent COVID-19 exposure. And then also we should be prescribing PrEP to all people who inject drugs. And the CDC clearly recommends PrEP to prevent HIV acquisition in adults and adolescent persons without acute or established HIV, who've had any injection drug use not prescribed by a clinician in the past 6 months, and at least one of the following. So any sharing of injection equipment or drug preparation equipment at least once in the last 6 months, and/or risk of sexual acquisition. And the CDC recommends daily continuous PrEP with either TDF-FTC or TAF and FDC.
Laura, I'm just giving you just letting you know it's 8:47. You're probably fine.
Yeah.
I'm sorry if you heard me bless you a second ago. Too.
Don't worry. No, two more slides.
No, you're fine.
Thank you. And we don't entirely know what's happening with access to PrEP during COVID-19, and particularly amongst people who inject drugs. But there were 2 studies that were presented at the International AIDS Conference this summer. I'm sorry, I'm ahead of myself, sorry. So first of all, PUID reported, so even prior to COVID, access to PrEP for people who inject drugs has been very limited. And in some observational studies and questionnaire surveys, PUID reported that competing health priorities, housing instability, periods of incarceration, side effect concerns, and HIV stigma all prevent access to PrEP. And one study from Baltimore, a city with high rates of injection drug use, found that only 25% of 265 PrEP eligible people who inject drugs surveyed had never even heard of PrEP. And only 2 reported that they were currently prescribed it, even though 63% reported they were interested in taking it. So again, we don't know, there's already very, very poor uptake of PrEP amongst people who inject drugs, and it's unclear what the impact of COVID is having on that access. But there were 2 studies, 2 abstracts presented at the International AIDS Conference this summer, looking at PrEP access, at least in gay and bisexual men. So the first was a survey of 394 men who were prescribed PrEP, and then also 188 healthcare providers across the U.S. What this survey showed was that there's a huge reduction in PrEP uptake. But it seemed that generally it was by choice rather than by restricted access. At the same time, the men that were surveyed also reported, far less sexual activity, less sexual partners, less, attempts to meet people via mobile apps. So perhaps, not an access issue, but really, just not accessing PrEP because of, reduced actual risk. And then secondly, a study from Fenway, which is an LGBTQ center in Boston, demonstrated a 72.1% reduction in patients starting PrEP and 191% increase in lapsed refills. So folks just not presenting for another refill when it was due, which, they also, hypothesized was again related to this, decreased need for PrEP, except that they found even higher lapse rates amongst younger individuals, transgender individuals, and ethnic minorities, possibly bringing into question that maybe this is more an access issue than a real decreased need. And then finally, we should be prescribing naloxone for all of our patients who are at risk, and really having this important conversation. One, as we know of increased fentanyl in the drug supply in San Diego, that talking to all of our patients about that, and making sure that all of our patients who are prescribed opioids of any kind, who use opioids of any kind, and even those that are using methamphetamine and cocaine, that they know that, or buying pills on the street, that any of those substances could be contaminated with fentanyl. And finally, here's a little plug for Pennsylvania. Feeling very proud of my birth state for carrying an election. And here's Governor Wolf and Lieutenant Governor Fetterman. So not only can Pennsylvania carry an election, but we can also reduce overdoses. And here they're getting trained on Narcan use. All right. That's it. Thank you very much, everyone, for your attention.
Thanks, Laura. We have actually a few questions that just came through in the chat. I don't know if you can see them. I'm happy to just read them to you. I'll read them so that you can start thinking. So Nettie Aldous asks, any loosening of buprenorphine prescribing license requirements on the horizon?
Yeah, so not so far. That's obviously been a huge push. We can prescribe Dilaudid and oxycodone, but you need, without a special license, but you need a special license to prescribe buprenorphine. The only relaxing that has happened is that, over the last 2 years, now physician assistants and NPs can prescribe buprenorphine. Unfortunately, whereas it's an 8-hour online training for MDs and DOs to be able to prescribe buprenorphine, it requires 24 hours training for NPs and PAs.
There also is a question, I'm not entirely sure what the sentiment is here, but what about fentanyl test strips? I don't know if that means access to them or, yeah, I'm not, sorry, Lori, I'm not sure if you want to unmute yourself. Or...
So fentanyl test strips have been promoted not only to be given out at syringe service programs so that individuals can test their samples. They're not FDA approved. Well, they're not FDA approved for point of care testing, even for urine drug screen testing. I would love to be able to get them here at the Owen clinic so we can at least tell patients in real time here at the clinic, based on their urine samples, if they're if the drugs that they're using may contain fentanyl, but there aren't any point of care FDA approved tests, though there are a lot of syringe service programs and harm reduction programs that are handing out the test strips so that folks can dilute the drug sample and dip the strip into the drug sample, and like a pregnancy test result will come back either positive or negative. There is a little bit of concern because they're not FDA approved, that could there be some of the other substances that are in the drug sample, could that interfere with the characteristics of the test? But I think that if it's a positive, that's very useful information. The concern is if it's a negative, does that give someone a false sense of security? So patients really should be counseled that even a negative result doesn't mean that the sample doesn't contain fentanyl.
And I was going to have Miley unmute herself because I think it's a good question. I think really the general point is, and this I think is seen in a lot of places where, the use of PrEP is really skewed and there aren't a lot of injection drug users who are using it. And it felt like, maybe that wasn't what they wanted first. They wanted other things. They wanted needle exchange. They wanted programs. do you think that that is shifting and that more people who inject drugs are more open to PrEP as a possibility? And then I'll also throw in my own question about long-acting injectable cabotegravir and where that might fit in for people who inject drugs.
I mean, I can only speak from Philadelphia, but I know that before I left, we were really trying to get a PrEP program up and running in the syringe service program there, and I know that Prevention Point is carrying that on with I think an enormous success. And they pair. I think it works. I think particularly well when you pair PrEP with other services. I mean, as Miley's pointing out, don't provide it in isolation, but provide it with a number of other services, so that if patients are presenting for PrEP, they're also able to access syringe exchange, buprenorphine, primary care, that it's just one of a whole menu of services that they're accessing simultaneously.
Right, nothing in a vacuum.
Yeah.
Make them all, bring it, should be a list of, or a menu of choices. What do you I have no idea if they will be starting to study cabotegravir in individuals who inject drugs. I'm sure a lot of people saw the data that came out on Monday for HPTN-084, that it worked in cisgender women. So I feel like this is the last group that we need to know about, and what a great intervention for them potentially. I just don't know where that is, globally. Do you have any sense?
Yeah, I don't know of any ongoing clinical trials with it, but I think it would obviously be a great option, particularly paired with not the injectable buprenorphine. So pair it with Sublocade or pair it with long-acting injectable naltrexone.
Right.
Yeah.
Seems like a no-brainer. We've got one more question, and then I think I'll call it. Do you have any data on persons who inject drugs that come across the border to Tijuana and back? I know this might be newer for you, Laura, but I don't know, what you've looked into.
Yeah, I don't. I don't know. Yeah, but I just from Philadelphia, we had this weird air bridge phenomenon when folks would come from Puerto Rico to Philadelphia, and mostly for treatment. So I don't know if that's what is happening. If it's what I know is that there are more folks probably going from San Diego to Tijuana for use, since I don't know what that's done to the supply and access. But that's.
And Lalo makes a really good point also. I don't know if you can see it, that in addition to everything we've talked about in HIV prevention, including PrEP, wound care services are really important as well, that people have access to. And I'm assuming at Prevention Point that was part of the menu of services. I don't know where that falls in.
Yeah, no, that was also part of the menu of wound care, skin and soft tissue, infection treatment. Yeah, all paired in one. And and I think the other thing is it's really harm reduction, meeting people where they're at, and that just because folks don't want to engage in all of those things that that I mentioned, letting them pick and choose what they can absorb on that day or in that moment, because I think facing not only his substance use disorder, but an HIV diagnosis or hepatitis C diagnosis and infections, all of that can be quite overwhelming, and allowing people to focus on one at a time. And I think it enormously it gives people a huge boost to their self-esteem when they can overcome one or tackle one thing, and then it's easier to kind of tackle others.
Great points. I think that is a nice way to end things. This was really such a great and comprehensive talk, Laura, and we really appreciate it. I hope things, it's hard to know how things are going to look as we stare at our numbers, our COVID numbers, and wonder how this keeps impacting our patients. But this was great. So thank you.
Thank you, Jill.
And I think next week we have another new Owen faculty member presenting, Robert Dice. So we'll have a couple of new folks, and that should be an interesting talk as well. But I hope everyone enjoys their weekend, get some rest, take deep breaths, all that good stuff. But yeah, thanks so much, Laura. Great talk. Lots of praise coming for you in the chat. Have a great weekend, everyone.